You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 22nd, 2020. This week, COVID, medical education, collider bias, Watchman, and ventricular tachycardia. First, a brief COVID update. When I recorded last week, there were 1.5 million cases in the U.S. Today, there are 1.6 million. The rate of growth last week was 1.15x, but it is now down to 1.06x, and that's slowing a bit. The U.S. deaths last week were 86,000, and today, 96,000. Growth is about the same as well at 1.12x. That's now about 5 weeks with these slight rises, and as states begin to open up, my guess is we are settling in for the new normal. A brief note from home. Kentucky has not had the official opening notice yet, but Louisville sits on the state line with Indiana, which has opened. The best cycling routes use roads in Indiana, and what's weird is when you ride your bike by there, you see people sitting outside in outdoor restaurants, and it looks hopeful. Now, a brief note on our hospital. We have seen a very slight uptick of patients with COVID, almost exclusively from nursing homes. We have very few patients in the ICU or on vents. Elective procedures have started, and the hospital census is coming back up in the range of about 70%, but not half empty anymore. Some furloughed workers are coming back as well. A special shout out this week. Last week I gave kudos to our pacemaker center. This week, our palliative care team has been stellar. All new patients with COVID who meet with palliative care early on. Remember what my wife Stacy says, palliative care are pals for people with serious disease. That leads me to another potential positive lesson from COVID. Imagine a world where all patients with serious frailty or multimorbid conditions who get admitted to the hospital for any life-threatening disease meet with palliative care early on. A practice like that might improve some of the inhumanity of end-of-life care in our country. A global note, there are now 5.1 million cases of COVID, with 2 million people recovered. Last week I worried about Brazil, and that worry looked well placed because Brazil now sits third in the world behind U.S. and Russia for COVID cases. Of course, I always keep an eye on Sweden with their laxer social distancing, and their COVID death rate per million of 380 is still less than Spain, UK, Italy, France, and Belgium. I still don't know what to make of India with its rate of death of only 2 per million. Second topic is COVID and medical education. My editor and site director, Tricia Ward, had an excellent column about 2 ID fellows from Harvard who are behind these YouTube COVID-19 literature updates. Doctors Eric Meyerowitz and Aaron Richterman have been doing these amazing 1-hour lecture series on YouTube. They say they spend up to 80 hours per week reading, prepping, making slides, and doing the presentation. Well, lectures like these have always gone on in teaching hospitals' classrooms, but the cool thing about this digital era, as opposed to the past analog era, is that in the old days, the only people who learned from them were those who showed up in that classroom. But now, that same lecture can be broadcast to billions. It's never been more important in the presence of a novel and global disease. And I think this represents really one of the positives of the digital era and social media. But of course, the education power of digital media is not exactly a new story, but what is new is that social distancing policies of COVID have greatly accelerated this trend for free, open access medical education, otherwise known as the hashtag FOAMMed. Medical meetings and grand round style lectures will eventually come back, but I look for more of these digital lectures to become a much more normal thing. Other groups doing amazing COVID education are the FLAIR group at Mass General, and of course Josh Farkas of the Pulmonary Critical Care blog and podcast. Statistician Professor Andrew Gelman writes often on his blog on COVID topics as well, and as a student of statistics, I love it. Now, the third topic, speaking of statistics, is collider bias. Medscape Internal Medicine had an excellent summary from Professor Tim Morris from the University of Bristol. He and colleagues had a beautiful preprint on collider bias, which he called the banana peel of COVID-19 research. You all should look at this paper and news story. Collider bias is pretty complicated, but if you don't want to be fooled by so-called paradoxes, it's a super important concept to learn. I've discussed it on the podcast previously in the setting of the obesity paradox. Hint, there is no obesity paradox. Being overweight is not protective. Rather, collider bias comes into play because of non-random sampling. In the obesity paradox, say for heart failure, researchers sample only patients admitted to the hospital for heart failure. The collider is something else that makes leaner patients admitted for heart failure seem sicker, like, say, COPD or cancer, etc., and thus obesity looks protective. As Professor Morris explains, the same issue of non-random sampling of retrospective studies is running rampant in COVID-19 research. One study recently even found smoking was protective for COVID. No, it's not a smoker's paradox, it's collider bias. I'm going to link to a study from Steven Stovitz in which they purposely sampled a hospital database selectively to show how obesity in children can look like it protects kids from getting diabetes. It is a brilliant, brilliant paper that I highly recommend reading, bookmarking, and going back often, as it's a classic case of collider bias. Next topic is the Watchman Registry. Back in March, at the ACC meeting, during the height of the pandemic when we weren't really paying attention, the NCDR registry of approximately 38,000 Watchman implants over a 2-year period between 2016 and 2018 was presented, and it was also published. The headline of the news story said, "Registry reports impressive procedural safety." Impressive. Now I'm going to quibble mildly with the modifier impressive. But let's first start with just a seconds-long intro on Watchman. The first fact is that in 2 pivotal RCTs, Protect and Prevail, Watchman did not meet non-inferiority to warfarin in the first primary endpoint, which was stroke, embolism, CV death. Non-inferiority was not met because ischemic strokes were higher in the Watchman arm. In the second co-primary efficacy endpoint, which excluded to 7 days after the procedure, but which patients gets to do that? The device barely met non-inferiority. In fact, if you accept non-inferiority of that second primary endpoint, you have to accept the possibility that Watchman could have been nearly 5-fold worse than warfarin. That's the upper bound of the credible interval. Second fact, based on this dubious evidence, you can call them priors if you will, Watchman was approved for use in patients who had high stroke risk and a reason not to be on long-term anticoagulation. But of course, since these patients were excluded from the trials, we don't have RCT-level evidence. In other words, approximately 38,000 U.S. patients had a foreign body placed in their heart, and we have no idea whether or not it helps them. Okay, now to the registry. The registry data is collected by people in hospitals, abstractors, that are often off-site or working for third parties. Our hospital collects data for the NCDR for other cardiac procedures, and I can say the data collection is not as rigorous as it is when research nurses enter data for RCTs. For instance, the Watchman Registry collects 220 data elements, again, entered by people not associated with the procedure. Now, the NCDR registry is better than a voluntary registry like Evolution, but it's hardly super reliable data. For instance, the authors write that the data quality is assessed by a random audit, but only 5% of the nearly 500 hospitals are audited. What's more, Watchman complications can occur post-hospitalizations. Things like stroke, bleeds, device-related thrombus will be missed by a paper that looks only at in-hospital complications. But to be fair, data collection for these later complications is being planned. Now, a word on the patients in this registry and indication creep. I noted that the median Hasbled score in this paper was 3. Now that would predict a modest rate of bleeding of 3.74 bleeds per 100 patient years. That's a risk level not usually considered high enough to warrant discontinuation of oral anticoagulation. But worse, nearly a third of patients in this registry had Hasbled scores of 0 to 2. So I asked, what was the contraindication to oral anticoagulation in these nearly 10,000 patients? Also, bleeding in this registry is labeled, quote, clinically relevant prior bleeding. The problem is that clinically relevant bleeding can look different to a Watchman operator who A, believes in the procedure, or B, might have a quota of procedures to meet so that the hospital can break even. The moral hazard of hitting these break-even numbers for left atrial appendage occlusion procedures in some U.S. hospitals should not be dismissed. Our hospital did not pursue a Watchman program, not only because I don't think it's effective, but because we felt it was impossible to hit that number. On the surface, then, the paper's report of 69% rate of prior bleeding looks like a reasonable number. But looking deeper, only 12% of these were intracranial bleeding, 42% were GI bleeds, but we have no breakout on these bleeds. Did they require a transfusion? Was it simply hemorrhoidal bleeding? Was it a polyp that was cauterized? And 6% of bleeds were nosebleeds. 15% were other. The bleeding issue is core because the vast majority of Watchman patients remain on antithrombotic therapy, usually in the form of aspirin, which we know from the Averroes study and BAFTA trials can be as hazardous as anticoagulation. There is also a not insignificant number of Watchman patients who have to remain on dual antiplatelet therapy or even oral anticoagulation. Now to the impressive complication rate. Again, counting only in-hospital complications, those recorded by an off-site abstractor, major complication rate was 2.1%, which sounds low. But you have to balance that 2.1% major complication rate against the possibility that there's no benefit from this device. 74 human beings died because of this procedure. Again, that's 0.2%, but we don't know whether there's benefit. Final point, among operators, the median number of left atrial appendage occlusion procedures performed annually was only 12, but most docs did less than 20 per year. This is American healthcare at its absolute worst. Most procedures are done by low-volume operators. Now, I have a good friend in Europe, and he's at one of the major left atrial appendage occlusion centers in the world. And he told me, John, it takes many hundreds of these procedures to get really comfortable, and even then, they have major complications. And then, the final thing I'll say about this before I move on to a more optimistic topic is that there were 38,000 patients in this registry. Think about it. If we had enrolled only a fraction of these 38,000 patients in a proper trial, we would have an answer as to whether this device or this focal strategy for a systemic disease is indeed beneficial. Okay, final topic and much more optimistic, ventricular tachycardia. Here's a scenario. A 65-year-old man had a large anterior MI in the past and bypass surgery many years ago, and he's doing everything right. He's taking his medicines, he lives a healthy lifestyle, but darn it, if he doesn't keep having ICD shocks for rapid VT from that scar. He's had 2 ablations by good places. They really tried hard. Lots of ablation in that huge anterior scar, but he still has multiple VT morphologies, and he keeps getting shocks from his ICD despite amiodarone. Now what? If he lived in St. Louis, one might refer him to Phil Kukulich and his team of radiation oncologists for consideration of, get this, radio ablation of VT. I've discussed this previously on the podcast, and it's pretty amazing. First, You do non-invasive mapping of the VT, have the patient wear a multi-electrode vest, and then induce VT with the ICD and map the VT. And then, with radiation oncologist, you design focal radiation to the area of the scar causing the VT. There's no IVs, there's no catheters. The patient gets off the table and walks out of the laboratory. Dr. Kukelich, along with Dr. Cliff Robinson and others, has published first a 5-patient case report in New England Journal, and then they published a larger series in circulation called the Encore VT study of 19 patients. And at this year's HRS, just a couple of weeks ago, Phil presented longer-term follow-up of the patients they have done. And of those patients in Encore VT, 78% had a reduced VT burden, no shocks at the 24-month follow-up. That is a little less than was at 6-month period. At 6 months, there were 94% reduced VT burden. Kukelich added that very few patients were actually cured of the VT, but most had only small amounts of VT. That's a significant improvement, though. At the end of 2 years, 52% of patients were alive. That seems low. But remember, these are patients with advanced heart failure. Most deaths in this series were attributable to heart failure, none related to the procedure. This is important work because the long-term effects of radiotherapy on tissue are well recognized, so you have to look at the long-term effects. And I'm proud to be participating in an organizing committee of the next step here, which is a large multi-center RCT. My friends, this is the way science should go. Case series looks promising, but then you must have RCTs. If this technology pans out, and it does look very promising, it will truly change the field of electrophysiology for the better. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating or write us a review. That really helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.